qualify for a traction splint, but when you do have a patient that qualifies, guys, this thing does wonders. All right, it's a great piece of equipment. It's not used immensely just because some of these patients don't fit the check marks. But it looks like a medieval torture device, okay? But this is way more humane than what you're gonna see them do in the trauma bay to patients with these femur fractures. They literally like get a lever pulley system with like sandbags and weights and stuff.
Nice.
Yeah, it's intense. All right, so they will typically come pre-packaged in a little baggie. Sometimes the baggie is not there. We usually keep these on the outside compartments of the truck. So this would again be something that you need to check off, not just the inside of the cab, but the outside of the truck. That's where we keep the backboards, the splint and stuff, the traction splint, the stair chair.
Extra seat.
And sometimes they're under the bench seat.
Sometimes. Oh yeah, they pop up.
Yeah. And the bench seat lifts up, you know, I'm talking about they can live underneath there.
So,
Well, this one here is an adult / pediatric, so it really doesn't work for people who are super big or super small. A lot of times you'll have an adult traction splint, which is a little bit bigger than this and works for a wider range of adults, and then a pediatric one. So you just have to look and see what you have. This is just what we happen to have here at the academy.
do we have pediatric ones on the truck?
No, not always, but sometimes they do. I've seen them. I've worked places that have them, so it just depends. Like Grady may not have them, but you might work for somebody else who does have them.
Okay. And typically, guys, if it's an adult, it's a one size fits all. So if you have Shaq as a patient, this probably will not work because it's not gonna be long enough. So just kind of, you'll see how we're gonna measure to see if it will work for the patient. Caleb, you might be questionable, Phil's got long legs, Michael, but, so, all right. Well, can I have a patient?
No, okay.
All right, actually sit down and face that way with your legs straight out.
This way? Okay.
You probably take off your shoe.
I take off my shoe? Okay, that's fine. Does it matter which leg?
Do you have stinky feet?
No, I just have not black socks on. Put my America socks on today, guys.
Alright, so who do you think would qualify for traction splint? Alright, so these are gonna be used for femur fractures. That's the only thing that we're gonna use them for. But there has to be other inclusive criteria for the traction splint. So we know it's a femur fracture. What else do we think has to be going on or not going on? It has to be a closed femur fracture. If we have a femur sticking out of the skin, if we have a compound fracture, we do not qualify for a traction splint. What else?
Can't have any other injuries to that leg.
The entire extremity from toe to hip cannot be compromised aside from the femur. We can't have an ankle fracture, we can't have a tib fib, a patella, we can't have anything going on with the hip. It has to be an isolated femur fracture of that entire lower extremity, and it has to be where does the fracture need to be?
Like mid-femur?
Midline
Midline.
or mid-shaft, okay? So it has to be a closed, isolated, mid-shaft femur fracture. And again, that's not always gonna check all those boxes for your patients. So closed, isolated, midline.
When you say isolated, is that including soft tissue injuries?
Not really, it depends on the extent of the soft tissue injury. If we've got like minor abrasions, lacerations, nothing crazy, we're more so thinking about the integrity of like the bone, the skeletal component, okay? All right, so if my patient fits all that criteria, okay, we're gonna get my traction splint out. And what we're gonna do is we're gonna come to the uninjured leg and we're gonna measure, okay? This little part right here, this little dip is gonna go right underneath the ischium, okay? So essentially right underneath the butt cheek. So we wanna place that about where that would lie here. And we want the very end where this is gonna be propped up, maybe.
I think we gotta tighten those black.
Yeah, these are, okay, we want it to be about a foot from the foot. Okay, that's the best way I can tell you to remember it. So where her foot ends, we want it to extend about 12 inches or a foot past right here. Okay, everybody good on how to measure so far? All right. Now, while I'm doing all this, my partner is gonna be the bad cop,
Oh no.
okay? Because guys, do we think femur fractures are painful?
Yeah.
Why? It's the biggest, thickest bone in the body. So the sheer force that it takes to cause a femur fracture, it's gonna hurt. Having that huge bone broken, it's gonna hurt. And because it's the biggest bone, it's weight supporting, it's surrounded by all of these really big, dense, strong quad muscles. Okay, everybody tracking? So if we have a fracture in that bone, most of the time, if it's a complete fracture, all of the muscles in my quads, they're gonna freak out too. They're gonna start to spaz, they're gonna start to constrict, okay? And if I have a complete fracture and all of these big, strong quad muscles are tensing, sometimes we can kind of have the bone kind of shift a little bit. It can be kind of like rubbing against itself, it can be rubbing against the nerves, the muscles that surround it. So a lot of times, instead of this and it just breaking and it's just hanging out like this broken, it'll break, my quad muscles will tense up, and it'll cause a shift in the like placement of both of the parts of the femur. So essentially, we've got like bone rubbing up against bone, okay? That makes it 1,000 times more painful. So the purpose of this traction splint is to literally pull this end of the broken femur to the point we're no longer rubbing against each other. So while we're getting this on, my partner is going to be pulling manual traction.
So I'm gonna hold her ankle like this and the leg.
Yeah, y'all
I'm
wanna
gonna
come,
pull.
y'all probably wanna walk around this side.
Oh, that sounds nice and painful.
And it's hard to do, it takes a lot of force to do it. But you're gonna hold her ankle and you're gonna support her leg and you're gonna be pulling, and I can do nothing else but this. It's not like I can be like, oh, here, let me help you. No,
Mhm.
I have to hold traction.
This is like C-spine. You do
Right.
not let go of this manual traction until the traction splint is completely secured, and then you can be hands-free, okay? So she's gonna be doing what this eventually will, pulling that manual traction, trying to get the bone kind of not shifting on itself, okay? So now that I've measured it, these little kind of twisty guys right here is what's gonna make it go shorter or longer, okay? So again, gonna go right here, ischium, butt cheek, about a foot from the foot, and then I'm gonna lock these guys in place so it'll maintain that length. Okay? Everybody good? Questions, comments, concerns so far?
How do you know that you're pulling it up?
Okay, so you're gonna feel like you're immensely hurting the patient, but when we get to that sweet spot of that traction and the bones are no longer doing this, it's still gonna hurt, but they're literally gonna take a sigh of relief and be like, oh, that feels better.
Okay.
So essentially, we're gonna pull until they stop screaming as much.
She's gonna pull until she stops screaming?
Well,
Or
it's
that's-
all right.
Yeah, you try.
Try.
It's not easy, depending especially on how big they are. If it's a smaller person, their muscles aren't as big. But if it's a big person, like for me to physically pull that hard would be difficult. But I'm trying.
You're trying to pull it apart some to give space between those bones? Is that what you're saying?
Or at least, cause they're probably, so this leg's gonna be shorter, right? Cause these bones have gone like this. That's why we measure on the good leg, because this leg's too short, probably.
Okay, I get it.
Okay,
Would you, the best way to place it on would be for them sitting up or laying down?
Oh, yeah.
either or, whatever the position of comfort is for the patient, we just need the leg to be
Straight as could be.
accessible and as straight as it possibly can be.
And for this, they would need to be able to keep their legs straight. It can't be like if they, you know how when we were splitting at that time, it was like that. Remember?
Like
Yeah,
the knee
no, it's
injury.
gonna have to be fully extended for the traction splint.
Because they aren't gonna have a knee injury, right? Or you wouldn't be using this, cause it's an
Right.
isolated mid-femur.
Okay.
That's why we don't use it very often. How often are you gonna break a bone
Just
that
that.
big and nothing else is injured? It's kind of a rare thing,
Mhm.
really.
Did we say this is gonna be painful?
Yes.
So, in the process of getting all of this, we need to be nice to our patient. Who do we need to call?
ALS.
We need to call ALS for what?
Pain.
Drugs, pain management, okay?
The good juice.
Depending on how close they are, we can maybe wait for ALS to get on board, to get pain meds on board before we apply the traction splint. But if they're 10-15 minutes away, this is gonna be the best thing we can do in your scope to kind of ease that pain is get this on. So just remember, you need to get ALS en route for pain management. Okay.
Would you check PMS before and after?
100%.
Just
Yep.
making sure.
Yeah, and again, it's just like any long bone injury, PMS before, after, okay? So now that I've got it measured, we're gonna come to this side over here. While my partner is holding,
Right, we wanna do that first, right, cause that can hold up.
while my partner is holding the manual traction, I'm also gonna give her a count. She's gonna kind of lift the extremity as a whole a little bit up so I can slide this up underneath my patient. So,
I gotta move my leg out of your way. Ready?
alright, count of 3, 1, 2, 3.
Oh, my butt cheek finger.
Alright, so now that it's in place, the very first thing you're going to put on is the ankle hitch, okay? We wanna get this on first because this is gonna allow my partner to have something to kind of hold on to better pull that manual traction.
And I can't let go while she does this.
Right,
She
it's
just
kind of
has to
like
work
working around C-spine. Alright, so the little stirrup is gonna go right underneath the heel of the patient. So the heel is gonna go in this little stirrup pocket right here. You're gonna notice there's a D-ring right here. This needs to be at the bottom of the patient's foot because that's what's gonna hook up to how we pull the traction, okay? There's gonna be an ankle strap that's gonna go around to secure this ankle hitch, and it can also, it's got a long tail, so you can pull it all the way around and get rid of all that slack, okay? My ankle hitch is on.
So now I can hold it like this.
Now my partner can better pull manual traction. Alright, the second attachment that needs to come on is gonna be up here at the top around the ischium, at the very top of the femur. Alright, so this also is gonna have just like a little thread and Velcro system. So we're gonna thread through here. Make sure it's nice and snug, okay? And guys, kind of like backboard strap snugness. If we do it super loose, this won't work effectively. If we do it super, super tight, it could cause more pain, restrict blood flow, et cetera, et cetera. So nice and snug, don't want it to go anywhere. Once this is attached, we're gonna find my, oh, no, didn't wanna do that, stand by. My additional Velcro straps, and these are just gonna go around the leg at different areas along the length of the leg. So we're gonna get one up here on the thigh. Do we wanna put one directly on the kneecap?
No.
Nope. Alright, let's kind of scoot that up a little bit. Alright, so palpate the patella. Make sure we're not putting that directly on the kneecap. We can scoot this one down a bit. Make sure the entire extremity is nice and secure, snugly secure to the splint.
For the thigh strap, relative to where the femur fracture is, where would you put it?
Well, so remember, fair, okay. Ideally, good point. We're gonna do some kind of minor palpation to find where the break is. So yes, we might need to go above or below.
Doesn't matter which. It's just around.
Typically, it'll be below because we have this one up top.
Mhm.
So just, but yeah, make sure if we can see where the break is, don't put this directly on top of the break.
If they start screaming.
All right, so now I'm gonna try to relieve my partner. These are a little finicky, different makes, different models, right? But they all have the same universal features. For this one, you have to pull this little knob out to kind of unlock the mechanism to get the appropriate slack here. Okay, we're gonna come over here. We're gonna hook this up to the D-ring, and then I'm going to crank, crank, crank,
Until they get relief.
crank.
Oh, that was about to say, please don't.
Okay,
Yeah, what is that?
It honestly, it
it's
does.
like a little
It's like-
inversion table.
It's a lot of pressure. It's a lot of pressure off my knees because
Yeah.
I have bad knees. So. It's a
So
lot of pressure off.
again, we're gonna crank this until my patient is, she's still gonna be hurting, but she's literally, and we're gonna talk to her and say, hey, this looks scary, this looks crazy, but I need you to tell me when you get to a point where the pain drops down significantly. Okay, if they kind of like sigh or they're like, oh wait, okay, that feels a little bit better, that's when we know we've hit the sweet spot with the traction. All right, If we need to, like if the patient's legs are longer or they're just a little bit more stretchy than the average patient, I don't know, you can always make this extend further if we're not able to hit the sweet spot, because I mean, some of the bones, they just kind of go like this up against each other. Some of them are just like completely parallel. So you can always adjust this, make it longer, same concept, pull until we have some relief. Okay?
The only thing to think about with that is they still have to fit in the back of the ambulance. You
Correct.
guys have been back there, right? Like the end of the stretcher's only like this far from the door. So you gotta figure out, like, are you gonna scoot them up further on the stretcher? Cause this is a lot of, she's got shorter legs, so you have more room to play with. But if you have a tall guy, you know what I mean? So just remember that when you're putting it on there, cause the last thing you wanna do is put them on there, slam the door, and, you know,
I had this guy that was like taller than the ambulance.
Yeah.
Not like,
the stretcher.
or like longer than the stretcher, and his feet were like, I was like, what?
And so guys, again, we need ALS, we definitely need pain management, we definitely need ALS for this patient. Once we get this on, please make sure if you guys, we need to have the patient as close to the stretcher as we possibly can, okay? So once we have this on, all we need to do is we're gonna use this to help lift this part of her body. We just need to be able to lift and set on the stretcher. The further you have to like manually carry somebody on this, it's a lot more cumbersome. If you are in a situation where you physically can't get the stretcher up to your patient, whether it's the elevator's broken, there's only, stairs, how do we get this patient down to the stretcher?
You move them first before you take it off?
It's not advised.
Oh, well, the mover thingy, right?
The stair
The little thing with the handles and you roll them on it, and it's like, I don't know what it's called.
The stair chair?
No,
The scoop?
it doesn't have
The
wheels.
scoop?
It's like,
Scoop stretcher?
no,
A mega move?
yes.
Okay, that's a good
Oh
idea.
my gosh, I couldn't remember the name, thank you.
But we wanna keep this as in line and having that traction pull as best as we can. Alright, why would we not ideally want to manually carry her without this on from 3 floors up down to the stretcher and then put this on?
You could drop me.
It can move around and.
Yeah,
destroy
guys,
more
cause remember,
muscles.
when bones break, they're not soft and pliable, right? What do we have running directly up against my femur?
Muscle.
That big old femoral artery. So the more we maneuver this before we have the traction splint applied, the more likely we are to compromise the arteries, surrounding tissues, muscles, et cetera, et cetera.
If we were to nick that, or if the artery were to be nicked, and,
Like you did it?
no,
I want to
Just-
rephrase the question.
it's not open, but it gets nicked, and they go into hypovolemia. Is there other signs to tell us that it's not just psychogenic?
Yes.
Like swell a lot?
Was it, okay.
We're gonna have massive swelling, and what's gonna start to happen to vitals, level of consciousness.
Alright.
Right, because with psychogenic shock, we do have that drop in blood pressure that causes that temporary loss of consciousness. So if they don't come out of that unconsciousness, we're gonna be like, okay, this isn't psychogenic, can you wake up now?
Will we put a tourniquet on that?
Sorry, what?
We'll put a tourniquet on
Where is she bleeding?
her for-
Internally, right? Cause it's closed.
She's bleeding internally. Do we put a tourniquet on internal bleeding?
No.
No. Drive fast. I mean, literally, that's all.
Why could we not?
And why couldn't, yeah,
Because it's so femoral, we'd still shut it off, we'd still stop.
Where do you know the compromise in the artery is? Cause it could be, the whole leg is gonna swell, right? It's not gonna swell just where the compromise in the artery is. So the whole entire thigh is gonna swell, and if you put a tourniquet here and it's up here, or if you put it here and it's further up, we could cause even more damage. We could cause like compartment syndrome, we could cause rhabdo, things of that nature. So yeah, we do not put tourniquets on extremities with internal bleeding. Okay? Any more questions?
So, how would you move her?
So we could attempt to get the patient on a backboard,
Okay.
right? we're not putting on our backboard because I'm concerned about spinal compromise, I'm using it as an extrication device. So we would lay her on a backboard the same that we would strap her, we obviously can't log roll her, right? But we would strap her just to keep her secure to the backboard. Don't bother with a seat collar, right? But we would need some extra hands because this is gonna jut past the backboard. So we would need somebody to kind of like support and spot that, but yeah.
Would the scoop stretcher be a good option?
Potentially,
Just to prevent,
potentially. It's not, the weight bearing load on the scoops is not as high than the backboard. So it just depends on the patient, the situation, how far you have to go, all of the above.
Can you stretch too far?
No, not really.
Okay.
Yeah,
Go at it.
just go for